Good afternoon, everybody. I'm Dr. Hridya.
Morgagnian cataracts with a turbid anterior chamber may look very alarming preoperatively, but just washing off the anterior chamber can clear the view. In any case of small pupil, I prefer using iris hooks because you never know the status of the zonules in these hypermature cataracts. As in this case, which looked perfect preoperatively, as I proceed with rhexis, I note an area of weakness inferiorly. There is resistance to performing rhexis, and you can slowly see the zonular dialysis appearing, and I have a rhexis extension in this area. So in Morgagnian cataracts, I prefer using a spiral rhexis, starting small, then going spirally, avoiding areas of calcification in the anterior capsule. This kind of helps in preventing a rhexis extension even in the presence of loose zonules. Coming to nucleus emulsification, the major challenge that I've faced is the extremely mobile nucleus which keeps moving and tilting, so you cannot get a good hold of the nucleus, as a result of which the chop is ineffective. So the solution is to stabilize the nucleus with a second instrument, bury the phaco probe in really well, and perform a horizontal chop so that you get a through and through separation. And these nuclei, although very small, they can be very leathery, so it is always safer to perform multiple chops prior to emulsification of the fragments. In this case, with very loose zonules, you can clearly see the dense matter that has seeped into the vitreous cavity. The bag was very floppy and it was coming into the phaco probe. So I'm performing emulsification very slowly in a more anterior plane with a lot of dispersive viscoelastic to push down the PC. IOL scaffold can be useful in these cases of floppy bags prior to emulsification of the last few fragments, so that the IOL pushes the posterior capsule down and prevents it from coming into the phaco probe and creating a hydrogenic PCR. This is a case of hypermature sclerotic cataract. It was impossible to perform rhexis using a 26 gauge needle, so I create a small hole in the area without calcification and proceed to fashion a circular rhexis using a 1-hour scissor.
Yes, sir.
Take mic, Rishi.
Sir?
Take mic.
So when you're doing one side and going to the other side, it may have been better to actually go for a micro-axis, and you would have gotten better access.
I know, sir, but
This-
it was not available in the peripheral
Okay.
center. That's why I had to go.
Or
with
you
this.
or you enlarge your side put and go for
Yeah.
it. You get a better control.
Yes, sir.
The area opposite to the subincisional area, there is dense adhesion and it is not accessible to the vena scissa. So I use a vitrectomy cutter to cut off these adhesions. Simply pulling the capsule in this area can cause an extension of rhexis. Here, after using the cutter, the rhexis is completed in a circular fashion, and the rest of the case goes unevenly as planned. In extremely loose bags, manual small incision cataract surgery can be quite effective, and after thorough vitrectomy, an iris claw lens can be implanted with good visual outcomes.
Thank you.
Thank you, Dr. Hridya. I think you covered almost entire spectrum of
Morgagnian
Morgagnian
cataracts
cataracts and
with
how difficult they can be. There is one more situation, like there may be that zonules are so weak and not able to chop the nucleus. In that case, what you do is put a CTR ring.
Yes.
Yeah. So that stretches the capsular bag and then you can easily chop
Yes.
the nucleus. That was the only thing which was missing in there.
very nice clutch of cases.
Thank you, sir.
The only thing I would have done, maybe in your first case especially, when there was so much space, I would have put the IOL scaffold much earlier than that.
Yes, sir.
As you rightly pointed out, many of these capsules are quite fragile and they always have a tendency to come towards the phacoprobe, and there's enough space created once that liquid milk comes out.
Yes, sir.
And you can
It was
implant
a
the lens.
very small nucleus, sir, so I thought I could just eat it off and then.
That's
put
what
in
is
the-
more dangerous. I mean,
Yes,
that keeps rolling around all
Yeah.
over. You don't get a good purchase on that.
Yes, sir.
And then once you have the intraocular lens in place, then
It's safer.
of course, a lot of dispersive viscoelastic has to be used.
So,
Anything to be added? Okay. Thank you so much, Dr.
Thank